Thank you very much. So, we know, everybody, that global, regional, and national burden of diabetes from 19 to 2022 is a campaign from the last information with a projection of prevalence to 2050. That means that in 2050, the number of patients with diabetes is so high that has created a problem, not sanitary problem, medical problems, even economic problems, and even a social problem. And the most important is that cardiovascular disease and CKD remain the leading cause of morbidity and mortality among persons with diabetes. So, the most important problems is that 30 to 40% of patients with diabetes of this huge epidemic is the CKD. And for that, now we have around 1 million persons in the world with CKD. That means that in every 7 patients, 1 is suffering with CKD. And in a tentative, in a effort to discover why diabetics die more than the other patients and why they are dying, it's this brilliant lecture, the brilliant information that is coming from kidney disease and explaining the role of the fact that why are dying younger diabetic patients. And for that has studied 10 years mortality by diabetes and kidney disease status of 15,000 patients. And they have seen that the presence of kidney disease in diabetes increase cardiovascular mortality by more than 6 times, confirming that diabetes with CKD is a cardiovascular disease risk accelerator. So when in the match is kidney problems, so we will have an excess mortality. And if you see the factors that influence in this cardiovascular, in this, let's say, fact that the diabetics are dying younger, is GFR and albuminuria. So GFR and albuminuria, that are biomarkers or kidney damage and kidney function, are 2 factors that are studied and presented even in system cohort presented in Diabetology 2022, that explain also that the decrease of eGFR and an increase of albuminuria are independently of each other and of common cardiovascular risk factor, and they are differentially associated with higher risk of various cardiovascular events and cardiovascular mortality in patients with diabetes mellitus. So, early measurement of both markers help to identify people with diabetes and higher cardiovascular risk providing. And not only they are providing additional information or specific cardiovascular disease subtypes, like coronary heart disease, stroke, myocardial infarction, cardiovascular mortality, and heart failure in women. So it's really very important to measure albuminuria. And moreover, cardio mortality according to UACR, confirming that albuminuria is a predictor of cardiovascular mortality in patients with diabetes. On the other side, this is very confirmed by the SHARM trial and SOLVE trial that confirm that apart the role of two big markers, eGFR and albuminuria, they are important even as a risk for HHF, that means hospitalization of heart failure patients. So we can insist, I insist that UACR is a strong independent predictor of adverse prognosis in high failure, irrespective of hypertension and type 2 diabetes. So, early diagnosis based on UACR can lead to prevention of cardiovascular events. See these slides because they are very important. The slides are coming from Fidelity. So, estimated 6 million individuals with T2D and albuminuria, CKD, eligible for finerenone, they have seen that 66% of these cardiovascular events could be prevented in individual diagnosis with CKD based only on UACR. And this is very important that you can prevent per 10,000 patients only with finerenone. And there are some big data and some very optimistic data. So I think that with these slides from Bakris, you can see that relationship between kidney and heart are something, a spousal relationship. Of course, with like this person that have some good relation with the spousal relationship. And if you see that kidney and the heart are together in marriage situation. If one spouse is not doing well, the health is not good. Then the other spouse is also suffering. So if the heart is failing, the kidney will try to support through compensatory mechanism, but is not going to be functioning as well as could. Likewise, if the kidney is failing, the heart will try to be supportive as it can, but it's going to be under influence that make it more difficult to perform well. So, how can we collaborate to achieve holistic heart and kidney management of patients with CKD and T2D? This is a very important question. And for that, I'll suggest that first of all, diabetologists should change the glucocentric approach of diabetes medication to deeper dive into the treatment of T2D with a strong focus on the role of newer medication in the prevention and management of comorbid cardiovascular and renal disease, opening so a new era of management of DKD. And all this study that you see on the left are studies that are using insulin and other old therapy, and they have seen that the role of them to protect the kidney and the cardiac problems are very low. So the second suggestion to my experience, to realize to achieve holistic heart and kidney management of patients with CKD and T2 is cardiologists must be convinced that the kidney disease is an important risk factor of cardiovascular disease. And this is confirmed by this study of circulation that you have to see. You have to see that preserving kidney function in patients with CKD is important. To protect the heart, you need to protect the kidney. And this is in ACC Congress 2023 in Amsterdam. Third, and what is more important, is that CKD, as jointly defined by UACR and EGFR, is a modifiable CV risk factor. Fidelity presented an opportunity to investigate whether CKD, as jointly defined by UACR and EGFR, is a modifiable cardiovascular factor. And this is the thing, more important things. Because I remember some discussions with some my friend cardiologists that are dissing to me that, okay, it's CKD is a factor. It's a factor very important. But what have to do you with a patient with CKD? We have nothing to do apart the allopurinol or apart the sodium bicarbonate. And now that you need, then they have to know that it's modifiable. And we have actually a lot of possibility to treat these patients and to create the basis to decrease the number of cardiovascular problems. And the fact that cardiovascular risk was reduced with finerenone across all the range of UACR and GFR, suggesting CKD is modifiable cardiovascular risk factor in patients with T2D. And here you see with this table, this finerenone reduced cardiovascular risk across all UACR and EGFR. 4, cardiologists must be convinced that to achieve this management, they must understand that as CKD progress, traditional risk factors contribute less to cardiovascular disease events than non-traditional risk factors. So, no, non-atherosclerotic causes contribute more than atherosclerotic causes as CKD progression. And I think that is something new and the point of view of this collaboration between endocrinologists, cardiologists, and nephrologists. And the strong overlap between heart disease, kidney disease, T2DM, and obesity, AHA, American Heart Association, has for the first time 5 days ago formally defined that they are calling cardiovascular kidney metabolic disease, cardiovascular kidney metabolic syndrome. Cardiovascular kidney metabolic syndrome leads to premature morbidity and mortality primarily because of a higher burden of cardiovascular disease. In addition, there are unique management considerations for individuals with established cardiovascular disease and coexistent metabolic risk factor, CKD, or both. And this syndrome is a systemic disorder that is very important, maybe even to change the philosophy of education, of specialization, and maybe so in the future, maybe we'll have some new specialty, cardiolog, nephrolog, and metabolic syndrome to be part of internal medicine, because the number of these patients is really very high. 5, to accept the evolution of pillars therapy to reduce high failure risk and slow CKD progress. And now, recent clinical guidelines for the management of CKD in T2D recommend a combination of drug therapy to optimally reduce risk. Pillar therapy. Because progression of CKD in diabetes is driven by the combined effects of hemodynamic, metabolic, inflammatory, and fibrotic factors. So, we suggest, or Bakris suggests for the first time in American Heart Journal, plus Cardiology Research and Practice in December 22, about the evolution of this pillar therapy to reduce heart failure risk and slow diabetic kidney disease. So the first elements are starting in 2001, 2018, and 2020. So, building upon the concept used by cardiologists in heart failure. From that was idea to this 3 pillar of therapy to reduce cardiorenal risk. And this, for the first time, were cardiologists to create this pillar therapy in the patients with heart failure. And after that, nephrologists and endocrinologists can apply the principle of 3 established pillars of therapy: ACE, ARB, first pillar, SGLT2 inhibitors, second pillar, and finerenone to reduce cardiorenal risk in diabetes as the third pillars. Let's see these pillars. The only proven treatment for renal protection in type 2 diabetes, RAS blockers, were in 2001 with renal and IDNT study. All these studies showed us that ARBs are effective for slowing progression of diabetic nephropathy. But however, you can see that apart this good effect, this is going to 16% risk reduction and 20% risk reduction, however, it remains a great residual work. And you can see residual risk in both treatment. And from 2021 or for 20,001, after these 2 big studies, we had a gap for more than 20 years, and this residual risk was going to send a lot of patients in dialysis. But in 22, we have some other development that I have to say to you, to describe to you in the second pillars. But before going here, we in Albania at least, I don't know where here in Greece, we have a problem with these patients that are taken ACE inhibitors, because cardiologists are discontinuing this agent when patients progress to advanced CKD. But this problem that I think was debated in Albania, and we had a lot of meetings with cardiologists to say that maybe it's not good because you are getting off or blocked a good class of medicaments. But finally, this study of New England Journal of Medicine, in a trial with 400 patients with advanced CKD, GFR 18 milliliter minute, and therapy with ACE inhibitor or ARB, were randomly assigned to continue or discontinue these drugs. And finally, the conclusion was the stop ACE inhibitors trial did not find any benefits for stopping AC inhibitor or ARBs in advanced and progressive CKD. And from 2 years, we suggest through some meetings, cardiologists, family doctors, not to stop these good classes that are part of the first very important pillar of reduce the CKD progression and cardiovascular disease. So the second pillar, a very nice classes that a lot of personality in cardiology, nephrology, and endocrinology are thinking that it's a classes that is staying close to aspirin, close to penicillin, and so maybe it's a class that will have probably a Nobel Prizes. And the philosophy of these classes, the philosophy as classes, is that apple, the forbidden fruit from Genesis. Forbidden fruit, it's a symbol that has continued the belief of humanity for centuries. And here means that you have to think different when we are going to treat a patient with CKD and cardiovascular disease. So this classes is isolated from the bark of the apple tree by Peterson, 1835. And this classes has the potence to protection, to cardiorenal protection in diabetic patients. And you see, slowing the progression of diabetic kidney disease from Olivia Blazek and George Bakris in Cell 2023, some weeks ago, they had a meta-analysis, fantastic meta-analysis, when we can see that they are able to reduce the risk of major adverse cardiovascular events, reduce the risk of hospitalization of heart failure, and to reduce the risk of kidney outcome. So this study, this meta-analysis, after some days later, is supported even from this other meta-analysis of cardiovascular outcome trial result among patients with diabetes with or at high risk for atherosclerotic cardiovascular disease, that is the principal cause of cardiovascular diseases. And absolute benefits of these classes in patients is not only in diabetic patients, but is also in patients without diabetes. These classes or these SGLT2 medicaments are cardiorenal risk reduction drug with glucose lowering, so with a beneficial side effect. And with DAPA-CKD and DAPA heart failure, result on can say SGLT2 are cardiorenal risk reduction drugs irrespective of glucose level. But RAS blockers and SGLT2 are not going to be the end of CKD. Patients with type 2 diabetes and CKD are yet at risk on CKD progression when treated with RAS and SGLT2 inhibitors. Because if you see, even after 2 classes, it remain a big gap, a residual risk, And this residual risk is because the very important role in the CKD progression is inflammation and fibrosis, that there are a potential treatment target to address the risk in CKD and type 2 diabetes. And you can see here this residual risk remain after treatment with RASI, after treatment with dapagliflozin, canagliflozin. It's a residual risk from inflammation, and fibrosis. So, finerenone recommended just for this gap, just for this residual risk, to treat patients with CKD, and is recommended as a core treatment pillar, not just only a third pillar, but as a core treatment pillar. So, the study of pathogenesis of CKD are getting some clear recommendation that MR overactivation is a key driver of heart and kidney disease, including heart failure. So, finerenone, a non-steroidal, highly selective MRI blocker, MR overactivation, which slow kidney and cardiovascular disease progression in patients with diabetes. So, this big study, these two big studies, Figaro and Fidelio, coming now to you by a pooled analysis, is saying that this pool analysis of fidelity, finerenone, significantly reduced the risk of cardiovascular death and first hospitalization, high failure. You see the reduced risk of first hospitalization from heart failure reduced 22%, and to reduce the risk of cardiovascular death and first high failure hospitalization 17%. On the other side, reduce risk of cardiovascular mortality and morbidity to 14%, and reduce risk of CKD progression, the more important for us as nephrology, to 23%. Also reducing albuminuria by 32%. For that, when you, for the first time, are treated with finerenone, that I have now in Albania more than 400 patients treated by finerenone, you will point to decrease less than 20–30%. If you see microalbuminuria, you have to focus to decrease under 30%. And these three pillars of therapy have slowed kidney disease progression by more than 50% compared to RAS blockers alone, reducing high failure hospitalization and the development of high failure and the risk of cardiovascular disease. Let's see this recommendation.
Time is up.
These three pillars of therapy are able to slow renal functional decline from around 10 to 12 milliliters per minute per year, loss in the early 18 to now about 2 to 3 milliliters per minute per year. So from 10 to 12 milliliters to lose for the year, we are going to lose only 2 to 3 million. And the average loss of kidney function in people without kidney disease of diabetes normally is around 0.7 to 0.9. This means that if a patient is going to dialysis here, treating by RASI, you are sending the patient in dialysis some years later.
You have 1 minute, man.
Yes, the 2, 3 last. Okay, I'm going to finish. From some days, we have not 3 pillars, but we have 4 pillars, because you see the semaglutide, the study of semaglutide, flow trial, focusing on slow CKD program was blocked because the results were perfect. 4 pillars. A, B, C, D, take home. I'm not reading, you have to see. It's my philosophy of treating CKD patients. Thank you.